Hello, welcome to the fifth NIHR Dementia Researcher Midday Lecture webinar. I'm Adam Smith and I'm the Programme Director for the NIHR National Director for Dementia Research based at University College London. Today I'm delighted to welcome Dr Courtney Genge. Hello Courtney.
Hi.
Courtney graduated in 2018 with a PhD in Dementia Studies after studying at Bradford Centre for Applied Dementia Research as part of their doctoral training centre on transitions in dementia care. In this webinar, Courtney will discuss her doctoral work on improving the quality and safety of care for people with dementia in emergency departments. I think you're going to explore the current experiences of staff, providing a framework as well for how we can improve in 5 key areas. You can find out more about Courtney through her bio, which is published on our website. The talk will be about 20 minutes, and then we've allowed 10 minutes at the end for questions, although if experience is anything to go by, we do often overrun slightly, so feel free to leave at any time. But if you do have any questions, if you use the Q&A box at the bottom of the screen, you can do that throughout the talk or at the end. And then what will happen is I will put the questions to Courtney at the end so she can answer those live. We are recording today's lecture, so if you drop out, don't worry. You can watch this back via our website at dementiaresearcher.nihr.ac.uk/webinars. And that'll be live from sometime tomorrow. So thank you very much, everybody, for joining. And thank you, Courtney. If you could share your screen now, and over to you.
Okay, so thanks so much for joining us this morning or this afternoon in the UK and giving me an opportunity to talk about my doctoral work on dementia-friendly emergency departments. So just to acknowledge, this work was made possible by the Alzheimer's Society of the United Kingdom, who provided funding for the doctoral work, which I did at the University of Bradford. And I just wanted to say thank you to my supervisors, Jerry Armitage and Andrea Capstick, also the panel of experts by experience who participated in the study throughout the course of the work. So today, I'm just going to give you a brief introduction as to why we need dementia-friendly emergency departments, tell you a little bit about what I did, and then really dive into some of those 5 key areas where there are some major challenges and also some opportunities for improvement. So why do we need emergency departments to be dementia-friendly? It's often emergency departments are thought of as transient care locations, where someone will only spend a couple of hours, but that's just not the case anymore. Especially for older adults and people living with cognitive impairment, emergency department wait times are going up all the time. And there's a lot of iatrogenic harms or hospital-acquired harms, healthcare-acquired harms, that have their roots in the care that's provided in an emergency department. That includes things like delirium, medication errors, sometimes unnecessary or invasive medical procedures, and also deconditioning. It can also be a place where the relationship with the healthcare staff in the hospital starts to deteriorate if there's a challenge with the relationship there. So it becomes a high-risk setting. It's also incredibly fast-paced, which is fundamentally misaligned with the needs of people who are living with dementia. It's also a vulnerable patient population. So older people, as a general statement, are often living with comorbidities, and emergency departments aren't the best at dealing with comorbidities. They're getting better, but originally emergency departments were set up for people with one acute challenge. And the challenges with dementia and comorbidities that they all interact. And it can be a real challenge when the entire system is set up for emergency conditions, when you've got people coming in with multiple comorbid conditions. The other reason that people with dementia are particularly vulnerable is dementia will often cause an impairment in communication. So in the emergency department setting, the patient is part of the care team and they act as an advocate and they also act as a carrier of information. When dementia impacts that ability to communicate for your own safety or advocate for your own safety, there's an added level of risk. So what this adds up to is an opportunity for high impact I was also aiming to understand the barriers and the facilitators of good dementia care to try and understand what was making it possible and what was making it harder. The other thing that I was looking for was what matters to people with dementia when they require care in the emergency department, so that we can target what we are advocating for change to really what is aligned with the needs of the patients who we're trying to improve the services for, and ultimately create a model of dementia-friendly care for the emergency department. So it was a multiple phase study that used mixed methods. I did 3 literature reviews over the course of my PhD, starting with a literature review on the experiences of care for people living with dementia in the hospital, and also the patient safety risks that were associated with being in the hospital for people with dementia. And we had to end up blending those 2 things together because there really wasn't very much literature about patient safety and the emergency department. The next thing that I did was a survey, which was co-designed with a panel of experts by experience because there wasn't a previously validated measure. So we developed a custom-built survey, which was administered nationally to people living with dementia and family caregivers who had had a recent experience of being in the hospital. So overall, we had 409 responses from across the country, 403 which were included in analysis. The third phase of the work was based out of 2 hospitals in the south of England. I did document review, 32 hours of observation, and 29 interviews with staff who were involved in providing care for people living with dementia. Now, those interviews looked at case studies, so 30 examples or 29 examples of when care went really well, and 29 examples of when care didn't go so well. And I was looking for patterns about what we could say was consistent when care went well versus when care didn't go so well. And the final phase of the work was a co-design session with people living with dementia and caregivers, where we examined all the data that had been collected and created a set of statements about what makes an emergency department dementia friendly. And then I compared those statements and the data that I collected to the geriatric emergency medicine literature, which is the 3rd literature review up there, to try and differentiate between what is geriatric friendly and what is dementia friendly. So let's jump into it. These are the 5 key elements that emerged from this research. And these were topics or areas that came up over and over again. They came up throughout all the different methods in different ways. And the reason that I'm proposing it as this 5 pillars model is because they're interconnected in a lot of different ways, and you can't tackle any one of them in isolation to try and move the needle on becoming dementia friendly. So what I'm going to do is I'm going to briefly walk you through what the findings of my research showed about each of these 5 pillars, and then talk about what the dementia friendly alternative could be. So the first things first is we can't talk about care in emergency department without commenting about care in the community. Because what's happening in the community is intimately linked with what's happening in the emergency department. So we hear over and over again that the emergency departments are overburdened and they're overused and they're crowded. And one of the reasons that's happening is because there's a lack of care in the community. Access to GP appointments is one thing, but there's also a shortage of health and social care in the community, which means that people are deteriorating in the community. It also means that the emergency departments can't necessarily discharge people who are medically fit to be discharged directly from the emergency department if they can't guarantee that there will be social services in place when that person is discharged. This is particularly true in the cases of palliative care or end-of-life care. People with dementia receive palliative care in the community far less than people with other terminal conditions. We also need to think about the fact that sometimes people are coming to the emergency department not because of a medical emergency, but because of caregiver burnout or a social emergency. There was a lot of people in the research who talked about 999 or 911 in Canada being the number that you know that you can call 24 hours a day, 7 days a week, and someone will be there. So it's seen as a safety net. As I was talking about a little bit earlier, emergency departments require information to make informed decisions, but the mechanisms for transferring health information or biographical information from the community into the hospital are not necessarily strong. And in a lot of cases, the person living with dementia isn't able to act as their own information carrier. So what you get is a lot of precautionary admissions where it's maybe borderline or even not medically necessary for someone to be coming in, but they are coming in. So just to sort of set the context that we really need to think about, you know, how's this positioned in the broader health system? I think nobody will be surprised when I say that the emergency department is busy, it's noisy, the lights are kept on for 24 hours a day. There's a real challenge with a lack of privacy, signage to direct people towards bathrooms or food and drink. And the challenge is that this environment is incredibly distressing for someone living with dementia. It's overstimulating and it's often anxiety provoking. So almost 70% of people who responded to the survey said that the person with dementia became more anxious or more agitated the longer that they spent in the emergency department. And that was really strongly associated with people saying that the noise made the person with dementia more agitated. And in fact, only about 25% of people felt that the emergency department was safe for someone living with dementia. And of that 25, only 3% of people strongly agreed that the emergency department was safe. And it's important to think about not just the impact on the patient, but also the impact on staff. The way that the physical environment is set up at the moment in the emergency department, it actually makes it harder for staff to provide care. The emergency departments, in a lot of cases, are now providing care for more people than they were ever set up to, which means that the care spaces are smaller. People are having to provide care in hallways or supply closets, and it increases the amount of strain that the staff are feeling, and it also increases the risk of a safety incident if there aren't clear lines of sight. This was a really interesting element of looking into the data collection, because when we talked to patients and caregivers, for the most part, they reported that the quality of the clinical care that they received was good or excellent, and yet they were still overall dissatisfied or unhappy with the care that they received because of the lack of dignity, the poor communication with the staff, the stress of the experience, and sometimes even feeling like the person with dementia was completely erased out of the experience of being in the hospital. But overall, they were relatively happy with the standard of clinical care. When you talk to the emergency department staff, they expressed a lot of anxiety around their inability to provide what they know to be best practice care, and also some concern about their medical competencies around geriatric conditions. And one of the ways that this manifests in the emergency department is in an increased number of safety incidents. So that includes things like medication issues, including inappropriate use of benzodiazepines and antipsychotics and sedatives, medical device injuries, so patient removal of catheters or IV lines, delirium, falls, or even poor or absent pain management when there's that poor understanding of how dementia and the clinical care interact in this setting. That's really closely linked into with the commentary that the staff made about their own training. So this was around, this looked at healthcare assistants as well as nurses of various levels and of experience, and physicians as well. And they all reported that their formal education had this excessive focus on the biomechanics of aging. And that everything that they were taught was largely theoretical. It didn't support them to provide good quality, holistic care to people living with dementia in the emergency department. And what you saw, in particular with the more senior nurses, was that they had a number of management skills or intervention skills that were, that supported them to provide non-pharmacological management of things like responsive behaviors or distressed behaviors, but those weren't routinely cascaded through training opportunities to the more junior staff. So what that has resulted in is an over-reliance on specialist teams, frailty teams, or dementia intervention teams. And the challenge with that is that there's too many patients in the emergency department with dementia to be relying on specialist teams to provide that care. There is an emerging consideration of the interplay between geriatrics and emergency medicine, but it's very new, and there's a lot of work to be done in this area about ensuring that medical training is aligned with the profile of the patients who are now being seen in the hospitals. And now this one, I think, is potentially the most important. So like I said at the beginning, I worked in 2 hospitals to do this research, and they had very different safety cultures and very different organizational cultures, and that manifested in the way that decisions were made. So for those who don't know, organizational culture is, it's sort of seen as how we do things around here. So it impacts how decisions get made, how resources get allocated, and it also can influence safety, because the culture impacts the safety because sometimes it becomes permissible to start working on the margins of safety, and that if it's accepted by the staff working in that area as a necessary risk, then you start to see those issues with safety culture popping up. And in my research, these differences in safety culture popped up in a lot of different ways, in particular around reactions and responses to potential safety risks, the way that safety risks and quality issues are dealt with by the management, and the way care is organized, whether it's holistic or medically focused. This comes, and it also involves sort of how family members are treated as part of the care team, or if they're perceived as visitors. So all of those things are intimately linked with the organizational culture. And I came up with this idea of this litmus test of, the cup of tea culture. So it's a very British thing. A cup of tea solves everything. But whether that cup of tea is considered an integral part of the healthcare or a nice to have that's an added extra on top of healthcare really influences the way that the structures and processes of care are organized. So if it's considered part of regular care, then you would expect to see the structures and the processes of care aligning to make it possible for that tea to be integrated into care. Whereas if it's seen as a nice extra, the responsibility falls on the individual who's caring for that patient to make it a priority. And it's more likely to drop to the bottom of the list when demands increase. So a couple of the key messages that came out of the study here were that the current model of emergency care, which tends to be disease-focused and episodic, is really misaligned with the needs of people who are people with cognitive impairment, who tend to be older adults living with comorbidities. The current model is also leading to poor outcomes and poor experiences of care for patients. And it's increasing the strain that the emergency department staff, and it's increasing the burden on caregivers who are trying to support their loved one with dementia in that setting. In order to improve, we have to move beyond this sort of simple cause and effect model. So what you see a lot in the literature around this is that organizations will implement a single intervention that tackles one of those 5 pillars, and then measure the impact and find that it didn't have an impact. So the initiative gets abandoned. So for example, they will implement a staff training program, and then they'll measure length of stay in a department, and then when the length of stay doesn't go down, they'll abandon the program and say that it wasn't successful, whereas it probably was successful, but it didn't adequately address the other drivers that were causing that poor experience of care and that increased length of stay. So it becomes the question of, so what now? What do we do now? And the answer is that we re-engineer our system to work towards a more dementia-friendly approach to care. And we're going to start with the organizational culture. And the most important thing about that is that people with dementia are treated with dignity and respect, and that underpins every interaction in the emergency department. And one of the things that I am really stressing is that we need to move away from this idea of dementia-friendly being sort of a nebulous, abstract concept of, a nice to have, and really start thinking about dementia-friendly as a commitment to fundamentally redesigning structures of care and processes of care to ensure that this particularly vulnerable group is safe. More involvement of family caregivers is also important, and this recognition that holistic and person-centered care isn't incompatible with emergency medicine. It just requires some tweaks to make it possible. So when we talk about re-engineering the system, it's really about making it easy for the staff to provide the care that they would like to be providing and that we know is better for the people living with dementia. In terms of clinical care, I'm not going to spend too much time talking about it because I'm not a clinician myself, but I will say that there are existing guidelines about what good clinical care for older people or people with cognitive impairment look like, and those are specific to the emergency department setting. I just don't know how well known they are. So I just want to highlight them, that if you're in Canada, there are the Geriatric Emergency Department Guidelines, and in the UK, the Silver Book recommendations. There also needs to be this recognition that geriatric competencies are core competencies for emergency medicine. They go hand in hand. And what we would be looking for in terms of clinical care in a dementia-friendly emergency department would be care processes that recognize that dementia does impact on cognitive ability. And when responsive or agitated behaviors are noted, that those would be interpreted through the lens of a manifestation of an unmet need. Physical environment. I know a lot of people think that this is the most important part of a dementia-friendly environment, and it plays a huge part. But I think you can have a dementia-friendly emergency department without making huge changes to the physical environment. So the changes that we would be looking for in a dementia-friendly environment would be things that protect privacy and dignity, that wherever possible, reduce overstimulation, support reorientation, and ensure that there is a preservation of function. So we don't want people leaving the department worse off than they came in. If they came in continent, we want them to leave continent. If they came in walking, we want them to leave walking. And it's about readjusting the built environment to facilitate that. And there's a number of things that can be done, including, noise canceling curtains, bedside lighting, making sure that there's clearly signed bathrooms, and reducing that high shine finish on the floor. Those are sort of small steps that you can take. You don't have to do a $200 million complete refresh of the environment. Now, that said, if you do happen to have $200 million sitting around and you're completely redesigning the emergency department, absolutely include those dementia-friendly design features. Use designs that enable those clear lines of sight to make it easier for staff. Use those private spaces where the environment can be controlled and stimulation can be controlled. Or even offer a quieter area within the emergency department. And those changes are actually going to support the staff because they're not fighting against the environment, they're working with the environment. In terms of what the staff were asking for to help them become more dementia friendly, they were absolutely explicit about this, in saying that the generic dementia training that they receive, it doesn't work. The skills that they're taught, the awareness that they're taught are not context specific. So there needs to be dementia specific training that is unique to the context of the emergency department. And they wanted it to be annual, compulsory, entirely stimulation-based, and focused in on practical skills for de-escalating or practical skills to facilitate assessment and treatment of someone living with dementia. And they were very clear that it needed to be paid, because that was the way that their organization could indicate to them that they valued this, this training. And they also were really interested in exploring opportunities for enhanced preceptorship or mentorship, so that more junior staff could learn from the more experienced staff. And the last thing here is that the emergency department needs to be positioned as part of a dementia-friendly care system. So wherever possible, building those connections with care in the community to divert away from inpatient care are important. There was some really great success stories of where home and community staff were actually embedded within the emergency department, which facilitated transfers. They were saying about 75% of patients could be reviewed and sent home with a package of care that same day, which is exceptional. So this idea of collaborating with partners in the community to develop rapid response teams, which can either divert away from the emergency department or facilitate smooth transitions without needing inpatient stay, that's great. And the other thing is providing referrals to palliative care programs for patients who are coming in end of life. I think there's a recognition that it's very scary to watch someone die if you don't have the right support. And a lot of people were commenting about coming into the department because they thought there could be a potentially reversible cause. And even though we know that the emergency department isn't a good place for someone who is dying, the families still need the support. So making those proactive referrals to palliative care can prevent emergency department visits in the future. So in conclusion, right now, emergency departments are not dementia friendly. But if we can reconceptualize this idea of dementia friendly as safety conscious, then we will be able to encourage that redesign that eventually will support better patient outcomes, and it will support staff to provide better care. Improving care in the emergency department, it can't be treated as a simple challenge. It has to be recognized for the complex challenge that it is. And that means trying to tackle each of these 5 elements and recognizing the interplay between all of them in terms of making progress towards dementia friendly. Now that said, just because there's 5 of them doesn't mean you shouldn't start doing work until everything is aligned. Don't let perfect be the enemy of progress. So yes, it would be better to have 100% of your staff trained, but 50% is better than none. And yes, it would be perfect to have, the entire department with, noise muffling curtains, but if you only have 2 bays, that's still better than none. So continually working towards that dementia-friendly shift. And that's where the organizational culture comes in. And really, I think that's the message that I would like to leave as the takeaway, that the most important thing here is creating that organizational culture where dementia-friendly care is prioritized, and the other things, they fall in line after that. But you have to have that organizational culture that says that dementia-friendly emergency departments or making care more dementia-friendly is a priority, and there will be a commitment to re-engineering the system to make that possible. So thank you very much for your time.
Thank you very much, Courtney. That was fascinating. And I should also mention as well that we've gotten you up particularly early this morning because you are in Canada right now. Of course, you're not based in the UK anymore. If anybody who has any questions now could start to post those using the Q&A button at the bottom. And if Courtney, you could stop sharing your screen now. I'm particularly fascinated by personally and some of the practicalities of conducting the research that you did. Obviously, emergency departments are particularly busy places, and accessing the staff. Were there some particularly unique challenges you faced in just delivering the research and gaining access to the staff in these places?
It was definitely a challenge. I approached about 6 hospitals before I found ones that were willing to participate. Now that said, they were very willing to participate. They saw a lot of value in the research that I was doing, provided that I was willing to be flexible. So I did a lot of work in the evenings or overnight. And the way that I set up the research data collection in terms of the interviews, it meant that we could split it into 15-minute chunks. So all I ever needed from a staff member was 15 minutes to talk, sometimes 2 15-minute segments, but it made it more practical to move towards data collection.
That makes sense. I can see a completely separate webinar or a blog just on, not so much on the research, but about the, how you deliver research in that setting, which I think provides some particularly unique challenges. Okay, we'll go to our questions now. Thank you very much, everybody who's posted. First of all, we'll go to Abby Wolf, who says, you referred to the geriatric emergency care guidelines. Did any of your research look or uncover any information about the perspective of individuals with young onset dementia visiting ER? When their visual appearance may not be congruent with widely held assumptions about age and dementia, they may have experienced other barriers. Accessing supportive care or ER staff may not think that their distress or symptoms are due to dementia. Good question.
Absolutely, Abby, that's a wonderful question. And in fact, there was a lot of individuals with young onset dementia who participated in the survey who said exactly that it was a major challenge for them because they weren't perceived to have dementia, and they had to, in fact, argue that they were living with dementia, which made their care even more complicated in their perception. I think one of the things to stress is that in that clinical care, one of the things that is one of the recommendations that's in the sort of long form of my thesis is that cognitive screening should be included in any triaging assessment, which would start to uncover those younger people who were living with dementia. And also that shared information between home and community, from primary care or from a memory clinic, that really should be accessible from the emergency department in order to optimize care for people who might not have that typical presentation of dementia.
Yeah, that's fantastic. Thank you very much for answering that. And I should add, I was just going to add to that. I think maybe I'm misremembering, but dementia assessments are, of course, part of the NHS requirements now, aren't they? That an assessment for dementia on people being admitted is a requirement. Whether it's conducted in A&E at that time, of course, I imagine is variable depending on the needs of the patient as they present.
I'd say the experience is it is inconsistently done. There's a perception that if the person is going to be admitted, then it would be done at the time of the decision to admit into the hospital. So you're either taken at your word when you say, I'm living with dementia, or my relative is living with dementia during that triaging process, or there's some sort of behavior that would raise a concern in the emergency department, which would indicate that testing was required. And interestingly, that's actually one of the things that fed into some of those safety incidents. So there was an example that was shared where the person didn't disclose that they had dementia. In fact, they were fine and dandy, and they gave a full medical history that sounded very accurate. And then they were administered medication, which had a negative reaction to something that they were taking because the medical history hadn't been accurate. And it caused a serious harm incident.
Yeah, I've come across those kind of occurrences myself, particularly where you're then so dependent upon the relative or their significant other to to provide information, because some people would just deny that they have that problem, or just not mention that difficulty. We've got another question now from Lauren Klutchler, who says, thank you for your presentation, Courtney. It was great. I have a couple of comments and questions for you. Number one, what additional changes would you suggest to make senior-friendly ED departments friendly? Are there anything you didn't already cover in your talk?
Yeah, about 25 pages of my thesis. That's a great
long list. I mean, the obvious things. I mean, there is research out there, aren't there? You know, is it University of Stirling particularly kind of concentrate a lot on environments? We know things like using colours on the warmer end of the spectrum make a difference. Not having patterns, strong patterns in materials. We know that white toilet seats can often become invisible, so introducing contrasting colours. Go on. These are just things that jump into my head, particularly for PCA. What else? Pick out a couple of things from your top list, Courtney.
So I think one of the most important things is around occupation. So regarding ensuring that there's something for someone living with dementia to do while they're in the department. That's something that is specific to cognitive impairment. And so making sure that there's activities and appropriate occupation for the emergency department. The other thing that I would say is a real focus on that organizational culture that recognizes that people living with dementia have additional needs, and that their cognitive impairment does make them more susceptible to decline. I think there's a lot of parallels between a dementia-friendly emergency department and a senior-friendly emergency department in terms of the physical design and in terms of the clinical competencies of the staff. But there's still, I think the biggest change is the organizational culture and how dementia is managed within that setting.
Yeah, absolutely. It's got to come down to the people, hasn't it? And I suppose that raises that good point. I don't know if it already exists or whether this was an output about that. You mentioned before about dementia-friendly training needs to be more specific to particular areas. I don't know if did you produce something to that end, or perhaps I know there are a few people who work in dementia-friendly environments on the webinar. Maybe you could post links to us if you're aware of this has happened elsewhere. Was that an?
It was on my list of research projects to do. In a way, I sort of shot myself in the foot because I finished a really exciting research project and then I shifted countries. So there was a lot of interest.
You need to come back. That sounds exactly the kind of thing that the Alzheimer's Society would love to fund. Lauren asked a second question. If you're looking for ways to support staff education, I would recommend looking at examples online. Oh, and then she's very kindly posted some links for us to share, which I will post alongside the recording of this.
Yeah, it's a great suggestion, and that blended online and in-person learning is something that I've used in another research project that I've been involved in since I've finished, and it was really successful. So it's definitely something I would be wanting to explore if I did go down that route of creating a training program for ED staff.
And Lauren's posted a link to a paper by V. Boscart, which says improving clinical outcomes for Canadian seniors, finding a pilot study evaluating applied stimulated and integrated learning approach, ASILA. So maybe we can, anybody who's listening can Google that to find the answer. Just a couple of, Mani Krishnan says, well done. So that's nice. Thank you very much, Mani. Puvana Pamaya says, have you had any response from organizations when you presented them with your recommendations? Their response, and did you feel there was any commitment from them? Yeah, so how did they respond to your feedback, and did they agree to change?
I think there was an excellent response when I presented the findings back to the to the organizations that I worked with. That's one of the reasons that I've reconceptualized this idea of dementia friendly as safety conscious, because that's something that they felt they could get their boards to buy into, that was a priority for their senior decision makers, and also something that they could get their staff on board with, because it was framed in this idea of making it easier for staff to provide the care that they would like to do. So I had a really positive response, and yeah, I think there was a lot of interest and a lot of, I can't say if there was uptake because I'm not in the UK anymore, so I haven't been able to keep my fingers in it, but there was a lot of enthusiasm about the recommendations.
Thank you. And certainly I know I've flagged up your work to the dementia friendly group that I'm involved with. Mani Krishnan, I suppose this is kind of adding to that point really, is how we're going to sell the concept to managers. Have you any thoughts on how we could make this appealing to the NHS to want to pick up and follow your guidance?
I think, again, going back to that idea of reconceptualizing it as safety conscious, and I'm dying to do a study where we actually implement these guidelines and then have a look at things like length of stay and inpatient stay and return to the community. I think the way that I would try and frame this is, if we can prevent deterioration in the emergency department, we can reduce the number of people who are in the hospital and potentially experiencing iatrogenic harm. And I would focus in very particularly on delirium, because we know that delirium increases length of inpatient stay, and it also has a significant negative impact on trajectory of cognitive decline, which has implications in terms of trajectories of care and whether or not someone can stay in the community. And that the environment of the emergency department is particularly deliriogenic. So, preventing delirium is going to reduce length of stay, is how I would try and sell that. Not to mention medication errors and falls and any of the other, negative impacts that could be influencing.
And we know from experience there, if there's any way to make NHS managers listen, it's to look to talk about things like anything that'll reduce admissions or reduce the delay on discharges, and improve that experience and transition through the system will always hit home, I think. Thank you very much for those questions. Stephen Williamson asked, as an operator, what are your recommendations for assisting a resident with dementia if there are multiple health systems located around your community? Which pillars of the ED department should we ask for change? I'm trying to understand the question. You might need to clarify that for us, Stephen. But recommendations for assisting with dementia with multiple health systems. I suppose, does this come round to where somebody presents? Because of course there's turning up in the A&E department, but there's also going to the local hospital or minor injuries and to GP surgery, special clinics and things.
Yeah. I think one of the really interesting things that I found when I was doing my survey is that a lot of people with dementia did seek care somewhere else in the community before they arrived at the emergency department. In fact, only about 16% of the respondents to the survey said that they made the decision to go to the emergency department, that was a decision that either was made by paramedics or was made by a general practitioner or a member of staff in a nursing home. So I think there's definitely an opportunity there to look into those health-seeking behaviors and around building those rapid response teams in the community, building paramedic capacity, building geriatric response teams in the community that might have enhanced ability to provide care in the home and provide packages of care. That would be, a real opportunity.
I don't know if it ever came to anything, but I remember when I was back in my Department of Health days looking at healthcare associated infections, there was some work then looking at when a care home resident particularly was going into hospital going to be going to the emergency department, but any information that the care home had on the person went with them, so that they were prepared. They weren't suddenly presented with somebody and having to take all that history at 2 o'clock in the morning, when obviously whatever their symptoms are impairing the person's ability to communicate their challenges, or even if they have dementia, they couldn't necessarily communicate that anyway. But the care homes played a role in making sure staff were aware, just to get that ahead of themselves, really. Do you know if does that happen?
Yeah, absolutely. That communication between nursing homes or even family members and the emergency department is absolutely core. And that comes down again to that communication piece in the community, and that connection between the community care. And it's also part of the organizational culture, because if that information doesn't come in, there's the culture of the place will really influence whether or not you pick up the phone and call and ask for the information, or whether you say, well, we don't have it, so we're going to make our best educated guess here, or we're going to use our clinical judgment. And that really comes down to the culture. And, you know, you see different cultures in different hospitals about, you know, how that's integrated into regular systems of assessment in the emergency department.
And there's another point here, but consistency is key, isn't it? I think it's being consistent even when, you know, like at the moment, the A&E departments are going to be under pressure. We're seeing, you know, more admissions, patients presenting with all kinds of things, and being able to still do that when you're at your busiest, or when it's 3 o'clock in the morning and it's different staff to the daytimes and things, is the key to doing that. But yeah, hospitals, the NHS is fantastic in that respect. They've got a lot of experience at making things happen. It's persuading them to pick up and prioritize one thing over another. Speaking of that, Manny Krishnan says, good to see you, Adam. This is Krish from Stockton at Tees Esconwere Valley NHS Foundation Trust. He says they need to do this. So that's good. Maybe we've got our first. Maybe Manny, Krish, you can get in touch with Courtney and she'll give you some advice and consult for you.
Happily, I'm
some extra
a lot of time right now.
I'd like to distantly consult with Tees Esconwere Valley Trust to help them make their emergency departments dementia friendly. Thank you very much, Manny. He's highlighting that they do the assessments, but they're not necessarily consistently applied. And Lauren just came back at the end to highlight they're not dementia specific, but principles could be used to develop education on this topic for this demographic. Fantastic. Thank you very much. I think that's the last of our questions. So thank you very much, Courtney. We're really grateful for you agreeing to share this with us today. If anybody has any questions that you couldn't ask today, you can find Courtney on Twitter at Courtney J. Shaw 1. I guess that's your maiden name.
It is.
And we will be posting a recording from today's webinar on our website later today or tomorrow. Our next webinar will be on Wednesday, the 29th of April, where we have Anna Volkmer discussing telehealth to enable access to interventions for people with dementia, particularly pertinent right now while we're trying to provide care at a distance. As I said, the recording from today and details on future webinars can be found on our website at dementiaresearcher.nihr.ac.uk/webinars. Finally, if you would like to join us and present your own research as a midday lecture, please drop us a line through the Contact Us page on our website, or you can DM us through our Twitter account, which is at dem_researcher. Thank you very much, everybody, again for joining us today, and thank you, Courtney.
Thanks, Adam.